my talk is all about hormone therapy, that is menopause hormone therapy. Oh my God, why is it not moving? What? It's not moving. Oh. Yeah, it's moving on that way. Well, actually, age of menopause is almost same since ancient time, but the longevity of life of women is prolonged, so a large proportion of women will suffer from consequences of menopause, like vasomotor symptoms, cardiovascular disease, genitourinary syndrome of menopause, osteoporosis. The role of MHT in ameliorating these debilitating conditions need to be so considered. The constantly changing landscape regarding the MHT or menopause hormone therapy has become challenging for providers and for the women as well. Since the Women's Health Initiative back in 2002, the healthcare providers are scared to prescribe MHT with the fear of breast cancer and coronary heart disease. Age and time since menopause affect the real balance of benefits and risk of hormone therapy. And that was actually by a study. So, Women's Health Initiative findings were again reanalyzed and revisited and found that the study was completely biased, where most of the women were more than age 60 years and who had already some diseases of coronary heart disease. So, and the study was concluded with only one kind of hormone therapy and one dose and one pattern. So it was not that valid that they said. But interestingly, the timing hypothesis is very important, which states that women under 60 years of age or women who are within 10 years of menopause, the benefits of hormone replacement therapy outweighs the risks of, and this is called the timing hypothesis. I mean, if an apparently healthy woman is there, and if we start the hormone below the age of 60 years, and she's completely, within 10 years of her menopause, the hormone replacement therapy really has very, very much benefits than the risks. And it becomes cardioprotective and it prevents osteoporosis because we all know that estrogen slows the progression of atherosclerosis and prevents the bone loss even in younger women. So the timing hypothesis, it says that the estrogen is very protective. It causes vasodilation, it decreases the inflammatory kinins, it causes the vasodilation. So if we start this estrogen, just at the beginning of the menopause, then it definitely works a lot. So the post-Women Health Initiative study said that in second analysis, the impact of avoiding estrogen therapy showed that many of women who were elderly, menopausal, had lot of consequences because of deprived of the hormone. So withholding MHT or hormone therapy deprives women her right and prevent the quality life. Evidences, there are a lot of evidences. IMS, International Menopause Society, and other most guidelines, that is endocrine menopause societies, recommend that hormone replacement therapy is for the management of menopause symptoms. But it is also true that American Society of the Family Planning and the Primary Prevention Studies say that hormone therapy should not be given to prevent some disease. Okay, she's apparently fine. She doesn't have any complications, any menopausal symptoms, but we started hormone therapy to prevent the cardiovascular disease, to prevent the dementia. It's not like that. The very recent study said, and it came in BMG, a 10-year MHT trial of DOP study, the Danish osteoporosis study, reported that the women taking MHT had a reduced risk of mortality, heart failure, then myocardial infarction without increased risk of stroke or cancer. And the KEEP study, that is coronary early estrogen prevention study trial, reported that MHT reduces menopausal symptoms, no doubt, but they failed to show any differences of carotid intima thickness. In a light study, early versus late intervention trial, that one group got the estrogen at an early age and one group got the estrogen at late age. It has been clearly shown that the who got the estrogen in early ages, they are much benefited. So what are the main concerns? Then why the providers, healthcare providers are scared to prescribe hormone therapy? You know that it has been shown in last Women Health Initiative that there's a risk, which is about, the number was breast cancer was 1 per 1,000 women use of hormone for 5 years. Only one extra cases per 1,000 women it was seen. And also the invasive breast cancer 2.5 and pulmonary embolism 3. And colorectal cancer was less, hip fracture was less, and all causes mortality was less. But I already mentioned that the study was biased. It is true that meta-analysis, including WHO study, found no increased stroke in women younger than 60 within the 10 years of menopause. And in an unopposed estrogen trial, it has been said that stroke risk was, stroke risk was significantly increased with conjugated equinestrone. But if somebody is taking this MHT transdermal, the incidence of stroke and thromboembolism can be avoided. Cardiovascular disease, well, Hurst showed that there is a risk of CHD, cardiovascular heart disease, increased when it was being used in young elderly women. But recent meta-analysis also stated that MHT within 10 years of menopause reduces the total mortality of cardiovascular 30% and cardiovascular disease 48%. It came in JAMA. Breast cancer, yes, WHI showed that the risk of invasive breast cancer was significantly increased with the hormone therapy I already mentioned. But lower rate of breast cancer risk was seen, a group of women who didn't use progesterone along with the estrogen. So it is very interesting that estrogen is not the culprit of the breast cancer. It is the progesterone which produces the breast cancer. Therefore, the risk of breast cancer is actually depending on the type of progesterone. And current MHT regimen typically includes estrogen, which is safer for breast cancer, and transdermal estrogen, which bypass the liver metabolism, thereby it is not increasing the coagulation problem. And also it chooses progesterone, which is friendly. Ovarian cancer, what about the ovarian cancer? Well, meta-analysis of 52 epidemiological studies suggested there's a very small risk of ovarian cancer of MHT, and the absolute number is very, very less. Yes, endometrial cancer, we all know that if estrogen is given alone in a women who are having uterus, there is endometrial hyperplasia, and subsequently, it may produce into endometrial cancer. But it is true, all the evidence showed that if we add progesterone with estrogen, then there will be no endometrial cancer. And that is why we use the progesterone along with progesterone. But one thing is important, the choice of estrogen, progesterone is very important. And now SERM, selective estrogen receptor modulator, came, and that actually doesn't do any endometrial hyperplasia. I already mentioned that progesterone is the culprit. So choice of progesterone is very important. But fortunately, oral microannualized progesterone is very, very safe. It is a natural progesterone. Didosterone is very safe. They have got a better safety profile than norethistérone, medroxyprogesterone acetate. So if we choose progesterone, we have to choose the natural progesterone. And we have to choose natural progesterone 200 milligram per day, either 12 days in a sequential way or continuously 100 milligram with the estrogen. Another very fascinating, levonorgestrel releasing intrauterine system, that is very good. It doesn't have, it doesn't do endometrial hyperplasia. It is not related to breast cancer. So if we give some estradiol and with levonorgestrel intrauterine system, then the endometrium is protected and patient gets benefits of the menopausal symptoms. And natural progesterone and didosterone should be chosen. We have talked lots about the risks of MHT. So we have to be very careful, individualize the patient according to my talk. And if we go for the benefits, there are a lot of benefits like MHT or hormone replacement therapy definitely ameliorates the vasomotor symptoms. It has been well established, evidence-based throughout the world. And it also improves the atrophy symptoms of the urogenital system like vaginal dryness, vulval dryness, dyspareunia. And it also improves the osteopenia and prevents osteoporosis. Particularly women with a premature ovarian insufficiency, MHT has to be given, and that has to be continued till the age of menopause, that is the age of 50. That is very important. And of course, we know that it has been evident that MHT or hormone therapy reduces the risk of colorectal cancer. And it is, it has been seen with the study that it decreases the colorectal cancer. And meta-analysis of 28 trials found there's no evidence of body weight gain. And weight gain, there's a myth that women think that if they take the hormone replacement therapy, they will put on weight. But actually, it is found that the hormone therapy is not the cause of weight gain. So this is the different type and doses. I can't actually finish my talk if I go through the doses, but these are the doses. Benefits for the heart disease, yes. IMS already told that it reduces the incidence of new onset of diabetes. That is fantastic. If somebody starts MHT within the 10 years of her age, menopause, then it will prevent the heart disease by, it also prevents the new onset of diabetes. It also improves the genitourinary syndrome of menopause. And finally, it improves the quality of life. What about the osteoporosis? Osteoporosis is the silent killer of fracture. Every 3 seconds, one man or woman is getting osteoporosis fracture. That is the most tragedy. And it has been seen that estrogen progesterone intervention trial, that bone density increase at lumbar, spine, femur in women who received 3 years of the hormone replacement therapy. Also, WHI showed that yes, there is an increased bone mass density. The osteoporotic fracture with combined hormone replacement therapy is reduced both in hip and other side. So estrogen therapy may improve also the balance, because when we are getting elderly, there's a problem with the balance and the fail, and that is the reason for fracture too. So estrogen also improves the balance of women. So how to prescribe? Definitely, when we are prescribing MHT to any lady or any woman, we have to get a thorough, detailed medical history, starting from her onsets of any disease, any medical disease like thromboembolism, any liver disease, and diabetes, how long the diabetes is, whether she has got family history of cancer, everything we have to take detailed history. And really she's suffering. Unnecessary, we should not give the hormone. If there's a clear indication that her menopausal symptoms are really bothering her and decreasing her quality of life, definitely we are going to decide to prescribe her hormone. Of course, we have to examine her blood pressure, her weight, her body mass index, her general examination, as well as para-abdominal and para-vaginal examination. Any unknown vaginal bleeding is a contraindication, is very, very bad for MHT. So we have to take the detailed history, examination, evaluation, and of course, some investigations. So when should we give somebody the hormone replacement therapy? Importantly, when somebody is having a clear indication of vasomotor symptoms. And to improve the urogenital symptoms. And when women are suffering from bone loss, when women are suffering from premature ovarian insufficiency. And what are the contraindications? That is very important. We have to keep our mind. What are the contraindications? Well, we have taken the history. We have examined her. She's fine. She has bothering symptom. Is there any contraindication we have to think about? Yes, the contraindication are unexplained vaginal bleeding, history of pulmonary embolism or thromboembolism, or in family breast or endometrial cancer, or she is having active liver disease. And of course, relative contraindications are, uncontrolled diabetes, uncontrolled hypertension. If these are controlled, we can start low dose hormone. So what are the formulation? I'm just showing the pictures because we don't have much time. There are cream, pessaries, tablets, transdermal patch, spray, lots, all type of hormones. That is combined estrogen progesterone, selective estrogen receptor modulators, tibolone, TSEC, tissue specific estrogen complex, and combination of estrogen dynages, that is a new one, and testosterone. These all are hormones. Dose, we have to start a very minimum dose so that maximum benefits can be gained and we can minimize the risks. And the interestingly, lower doses are also associated with less vaginal bleeding, less breast tenderness, and fewer effects on the coagulation and anti-inflammatory markers. And possibly this lowers the risk of venous thromboembolism than the standard or high dose. Yes, this is one graph where it's showing that, you see, if somebody is having the history of stroke or she's high risk, then we can omit the oral estrogen. We can start transdermal estrogen, which bypass the liver metabolism. Thereby, it doesn't alter the coagulation factors. So there's no risk of thromboembolism or heart disease. Yes, once the women we have prescribed the hormone therapy, we have to follow up. We have to monitor her, how she is. Because before starting hormone replacement therapy, we have to be very, very honest. We have to discuss about the risks and benefits, pros and cons. And then we have to take both together a shared decision. And we start the hormone replacement therapy according to the patient's choice, and we have to monitor 6 monthly. How she's feeling. Is she okay? Is she getting the benefits? Is there any side effects? Everything we need to follow up. And investigation, actually, it needs to be individualized. If somebody is having history of fragile fracture, definitely we're going to do the DEXA, heart bone mass density. And mammograph also we can do, and accordingly. And if somebody is having unexplained vaginal bleeding, then we have to be very, very careful why she's having bleeding. Though initially, there could be some bleeding 3 to 6 months, and we can go for the transvaginal sonogram to see the endometrial thickness. If it is not that thick, we can wait and see. But if it is repeating, then we have to go for the curettage. So fine, if somebody, the hormone suits her very well, then how long you will continue? Is it for lifelong or 1 year? And if she's fine, better, now do you like to stop it? Well, in the past, we had a notion that hormone replacement therapy should not be continued more than 5 years. Because why? After 5 years, the maximum benefits wanes off and the risk starts to begin. So 5 years is the very good time within which a women can get lots of benefits from the hormone replacement therapy. But the notion has been changed during this decade. It has been seen that, well, actually, if a woman is apparently healthy and if hormone suits her, she might continue as long as she desires. But definitely, we have to discuss again the risk and benefit, and she should be under regular monitoring. Because after 6 months or yearly, when she's coming, we had to go for the reassessment, evaluation, and further counseling, and it is very important. What about it? And now I discussed all about the estrogen and progesterone. Of course, if somebody is having uterus, we have to give her progesterone. This is must. Tibolone is one kind of menopausal hormone therapy, which is having estrogenic activity, progesteronic activity, and androgenic activity. So it also ameliorates the vasomotor symptoms, it prevents bone loss, reduces fracture. And the beauty of tibolone is that it doesn't increase the endometrial hyperplasia, and it has less invasive breast cancer incidence. But if somebody has breast cancer history, we are not going to prescribe the tibolone. And this is the new one that contains combined estradiol and dinogest. It is very promising. Latestly it came up, and it also reduces the mental, it also improves the mental health. So combination of 2 mg estradiol valerate with dinogest regarded as an effective and safe treatment option for women with mild moderate depression, and of course the context of postmenopausal syndrome. It's very good. TSIC is a very new one, where here the conjugated echinacea and bedodoxyfen are being combined, which ameliorates the vasomotor symptom, but it doesn't increase the endometrial hyperplasia. That we can avoid the progesterone, because progesterone has a lot of issue with the breast cancer. So that is very good, and it also improves the quality of life, improves the sleep disorder. That is the abstract came up just new. Testosterone is very important. Many women and many men are, fond of testosterone because along with the menopause, testosterone deficiency occurs. But one thing is very important. International Menopause Society said that testosterone cannot be used discriminately. Only it can be used if some women, postmenopausal women, are suffering from hypoactive desire, hyperactive desire deficiency syndrome. Then we only can prescribe the testosterone. So I would like to conclude with my time. That is hormone replacement therapy or menopausal hormone therapy should be given to women for when it is indicated to improve the quality of life. And she should be informed about all the pros and cons of the hormone so that we can take the shared decision, that is the women and the healthcare providers. MHT or hormone therapy starting at window opportunity. That means within say 10 years of age of menopause, young women, that with the minimum dose, that will actually maximize the benefits and minimize the risks of hormone replacement therapy. But still, we need more research. I still need it for all about the hormone therapy. Thank you very much for kind attention. So if there is any question, I can answer to you. Thank you very much.